We'll discuss about overbite. What is overbite? Profit has defined overbite as a vertical overlap of the incisor teeth with the posterior teeth are in contact. And Bishara has given the definition as debite as an aberration in the overlap between the maxillary and the mandibular incisors. There are different terminologies that are used for the deep bite. There includes deep overbite, cover bite, close bite, duck bite, and duck bite, and the posterior collapse bite. The classification: dento-alveolar deep bite and skeletal deep bite. Hodge and Mullman has given the classification in 1952 as true deep bite and pseudo deep bite. Ackley has given the classification in 1977 as type 1, type 2, type 3, and type 4. And another classification is the simple deep bite and the complex deep bite, and incomplete deep bite and the complete deep bite. Dento-alveolar deep bite. The deep bite due to infraocclusion of the molars have the following features. Molars are partially erupted, interocclusal space is large, lateral tongue thrust, the distance between the maxillary and mandibular basal planes are short. Deep bite due to supra-eruption of the incisors has the following features. The incisor margins of the incisors extends beyond the functional occlusal plane. The molars are fully erupted, the curve of P is excessive, and the interocclusal space is small. Dento-alveolar deep bite. The growth pattern is usually in average or towards the vertical. The deep overbite in these cases can be compensated by anti-inclination of the maxilla. The lingual tipping of the lower incisor and infraposition of the first molar as a downward and backward rotation of the mandible is to be expected. The prognosis for therapeutic bite opening is favorable. Skeletal deep bite, it is usually genetic origin. It's characterized by horizontal growth pattern. The skeletal deep bite due to upward and forward rotation of the mandible. The skeletal deep bite due to downward and forward rotation of the maxilla, and the skeletal deep bite due to combination of A and B, convergent rotation. True deep bite, it is due to the infraocclusion of the molars and lateral tongue posture of thrust. Pseudo deep bite, it is due to supra-eruption of the incisors. The molars are normally erupted. There is a small interocclusal space. Simple deep bite, it is localized to the teeth and alveolar process in the anterior region. The upper and the lower incisors are extruded. The result may be labioversion of the upper incisors and impingement of the lower incisors into the palatal mucosa. Complex deep bite, it is a deep bite associated with basic skeletal features. The horizontal planes are nearly parallel to each other and the gonial angle is less than normal. Total anterior facial height is approximately equals the posterior facial height. A complex deep bite is frequently associated with the class 2 malocclusion and occasionally associated with class 3 malocclusion. Incomplete deep bite, it is an incisor relationship in which the lower incisor fails to occlude with either the upper incisors or the mucosa of the palate when the teeth are occluded. And complete deep bite is the relationship in which the lower incisors contact the palatal surface of the upper incisors or the palatal tissues when the teeth are in contact. Coming to the etiology, there are inherent factors as well as acquired factors. What are the inherent factors? One is the tooth morphology, skeletal pattern and the malocclusion, and the condylar growth pattern. Acquired factors include the muscular habits, changes in the tooth position, the loss of posterior supporting teeth, and the lateral tongue thrusting habit. Diagnosis of deep bite includes clinical examination, study model, cephalograms, and photographs. Coming to the management, treatment modalities, different methods of treatment are available. Methods are intrusion of the anterior teeth, extrusion of the posterior teeth, combination of both, proclination of the incisor, distal tipping of the molars, and surgical. For the deep bite correction with the removal appliance, usually use an acrylic bite plane or an anterior bite plane. That is a removal appliance. Hall is a removable appliance with anterior bite plane, which causes when the teeth comes into contact, causes disocclusion of the posterior teeth, and there will be posterior suppression of the posterior teeth, and it will correct the deep bite. It is advisable not to disocclude the posterior teeth more than 2 millimeters. The posterior tongue creep, lateral tongue thrust during functional deep bite due to infraocclusion of the molars. This true deep bite is called as functional deep bite. In these cases, posterior tongue crib is used. It is placed in the area of infraoccluded teeth. It prevents the tongue from inserting into the interocclusal space during the postural rest position. Deep bite correction with the myofunctional appliances. Deep bite due to developing class 2 division 1 pattern can be intercepted with the myofunctional appliances like activators and bionator. The deep bite cases diagnosed to be due to infraocclusion of the molars can be treated by an activator designed and trimmed to allow the extrusion of these teeth. The interocclusal acrylic is trimmed gradually to encourage the eruption of the posterior teeth. Bionators. Bionators can also be used for a similar purpose. Frangles appliance. For the correction of the deep bite, Frangles 1A or 1B appliance can be used. Increase of vertical extraoral space is possible because the construction bite is taken so that the bite is open in the posterior segments as the mandible is held forward. Frangle feels that the disturbance in the vertical development is more often caused by the cheeks than the effect of the tongue. Twin block appliance. Deep overbite by twin block is reduced by vertical overcorrection to an edge-to-edge incisor relationship with the interincisor clearance of 2 to 3 mm in the protrusive bites. Occlusal cover of the posterior molars of 1 mm is equivalent to 3 mm to 4 mm vertical clearance in the first premolar region. Deep bite correction with orthopedic appliances. Headgears. When an extremely deep overbite is present because of the over-eruption of the maxillary anterior teeth, a high pull headgear can be attached to the anterior segment of the arch wire in an attempt to intrude this teeth. The cervical headgear with its downward vector of force increases lower facial height by extruding the molars. Occipital pull with intraoral attachments between the canine and the lateral incisors is used for deep bite cases. When a J-hook headgear with occipital pull is used, the force vector is further forward so that it tends to have an intrusive force to the maxillary incisors and may have an indirect extrusive force to the maxillary molars as a result of upward tipping of the occlusal plane anteriorly. Deep bite correction with fixed appliances. These fixed appliances also can be used to intrude the incisors or extrude the molars. They also produce mild skeletal effects. And the appliances used for deep bite corrections are generally termed as intrusion arches, and variations include base arches, utility arches, Connecticut arch, and reverse covers PYS, etc. Fixed bite planes like modified Nance appliance, bonded bite plane with composite resin, acrylic lingual bite planes, and temporary bite razors. Correction of deep bite with magnets. Usually use samarium cobalt or aluminum nickel cobalt magnets, but samarium cobalt is preferred over aluminum nickel cobalt because of their superior properties. They are used on the buccal as well as the lingual or palatal side, but commonly used on the buccal side in attracting mode. The force generated may average 120 grams, which may be controlled by the operator by adjustments of the air gaps. Less air gaps between the magnets generate more force. Correction of the deep bite with orthodontics and surgery. An adult who has more than 6 mm overbite or 8 mm of overjet could be considered as a candidate for surgery solely on the basis of dental relationship without even considering facial aesthetics. The surgical treatment options in deep bite patients are orthodontics and interpositional genioplasty, orthodontics and inferior only mandibuloplasty, orthodontics and mandibular advancement, orthodontics and total subapical mandibular advancement, orthodontics and inferior repositioning of the maxilla and the mandibular advancement, orthodontics and combining maxillary and mandibular surgery. Thank you.